We are live.
A very good evening to all of you, and welcome to lecture 521 and the 12th lecture in the series of Eye and Systemic Disease. And we welcome the man who needs no introduction, rather, the man who volunteers not to be introduced out of his evergreen humility and expertise in the field of ocular oncology. So let's hear it from the father of Indian oncology about eye and systemic cancers. Over to you, Dr. Honavar.
Thank you so much. As part of this very extensive series on eye and systemic diseases, today we are going to talk about eye in systemic cancers. Now, when we talk about eye in systemic cancers, we can have a loose classification: metastasis to the uveal tract, retina, orbit, adnexa, direct extension into the orbit through paranasal sinus, nasopharynx. Hematological malignancies and lymphomas specifically cause infiltration and hemorrhages, and they also affect the eye by means of anemic retinopathy. Then there are paraneoplastic syndromes, which are autoimmune retinopathies, neuroophthalmic manifestations, etc. Of course, we should not exclude treatment-related toxicities due to chemotherapy, radiotherapy, and target therapy. And finally, opportunistic infections. I may not be able to cover all of this, but I'll try to cover at least the important ones. Let's start with metastasis. Now, these are the sites of primary cancers from which metastasis happens to the eye. Of course, it depends on the series, but breast remains the commonest, 40 to 53%. Lung comes next, then come everything else. GI cancers, especially colorectal, melanomas, then hematological malignancies. Now, depending on the primary cancer, there are specific ocular manifestations as well. For example, melanoma does manifest in terms of retinal metastasis, but more commonly melanoma-associated retinopathy. Leukemia and lymphoma cause retinal infiltrations more often than not, whereas CA breast and lung go into the choroid. CA lung, especially small cell lung carcinoma, causes cancer-associated retinopathy. So there are specific manifestations for each of the primaries that you should understand. Megha, what is MEI? Yes. Or in other words, why is choroid or uvea the most common site for metastasis? There are
Because
so
it
many
has
organs.
rich vascularity.
Mhm.
So
How
that is
much
why
is the
there is a
vascularity? How much do you think is the vascularity?
how
How
much?
much does flows into the eye with every pulse?
I don't know. So
You don't know. MEI is
that
metastasis
is
efficiency
extent.
index. It's the rough percentage of involvement of a specific organ divided by blood flow to the organ in terms of ml per minute, right? So there is what is called seed and soil hypothesis. Choroid is one of the most vascularized tissues in the body, as you rightly said, but it receives only a minuscule of cardiac output. About 0.6 to 0.8 ml of blood is pumped into the eye, of which choroid hogs about 80 to 85%. So it is the most vascular structure in the eye, but it may not be the most vascular structure in the body. There are other structures that get more of blood supply, but it also has what is called anatomical mechanical predisposition. The architecture of the choroidal vessels is such that there is interaction between adhesion molecules on the surface of the cancer cells and the endothelial ligand sites, and also the specific architecture of the choroidal vasculature traps cancer cells. That is one of the theories. So putting all this together, choroid gets about 8 to 10% of metastasis. In fact, it is one of the most common sites for metastasis, more common sometimes than lung and bone, which are other two most vascular organs. Now, if somebody asks you what is the most common intraocular malignancy in adults, the answer would be uveal metastasis or choroidal metastasis. Both are right. Uveal metastasis as a group, iris, ciliary body, and choroid, or choroidal metastasis by itself also stands alone as the most common intraocular malignancy in adults. This is from the largest series of shields: breast 37%, lung 26%, kidney 4%, GI tract 4%, cutaneous melanoma 2%, and everything else in a much smaller percentage. But if you investigate 100 patients of uveal metastasis for a possible primary site, about 12 to 16% of them will turn out to be negative on all possible investigations. That's for some curious reason. Of course, they can get metachronous primary. Means that the primary may have been too small, or in certain situations such as adenocarcinoma of the colon, if it is of a polypoidal architecture, it is prone to necrosis. And once it necroses and gets flushed out, the primary may not be big enough to be visualized on PET CT scan. Unless you do a colonoscopy, it may be missed. So necrotic tumors can be missed. Now, if you want to know what is the percentage of incidence of uveal metastasis among choroid, iris, and ciliary body is the least. Choroid 90%, iris 8%, and ciliary body only 2%. That's a rough data. Let's start with iris. Let's go from anterior to posterior. This is a patient with CA lung, presents with this nodule in the iris. It can easily be mistaken as granulomatous uveitis. So, unless careful attention is paid to history, or if the patient does not have a known primary already, perhaps this is the first manifestation for the patient, and he doesn't know that there is a primary already, then it can easily be mistaken to be a case of granulomatous uveitis and treated with topical steroids. Not to miss all this florid NVI, and in some patients, you will even have exudation. In fact, when a tumor metastasizes, it carries its primary traits along with it. If it's an adenocarcinoma that metastasizes, it presents with multiple iris nodules, and the exudative nature of the adenocarcinoma will cause hypopyon. This yellowish hypopyon and this yellowish nodules turning the entire iris into yellowish hue, very characteristic of adenocarcinoma metastasizing into the iris. So if you carefully look at the metastasis, you may sometimes be able to predict the primary tumor as well. Whereas lung carcinoma generally presents with nodules like this with gross neovascularization of the iris. Adenocarcinoma, for some reason, does not cause neovascularization of the iris. Whereas adenocarcinoma presents with elevated intraocular pressure because this exudative material, exudated material, clogs the trabecular meshwork and raises intraocular pressure. Now, if you have a, say, one of you can take this. If you have a 60-year-old male or a female presenting to you with white eye hypopyon, there is no ciliary congestion at all, correct? Little bit of conjunctival congestion, possibly due to examination and the dilatation, the whole process that you have performed on the eye, but otherwise, there's absolutely a white eye. There may be what looks like a fibrin membrane on the anterior lens capsule, but otherwise it's a white eye leveled hypopyon. So what are the possibilities here? You have a white eye hypopyon. You're not talking about uveitis, especially in an elderly individual. Uveitis is rather uncommon. And if you have a white eye hypopyon without any ciliary congestion, you will be thinking of large cell lymphoma or leukemia. Those are the two possibilities. Of course, there are other reasons as well. But in a child, the reasons will be different. You'll think more in terms of retinoblastoma than anything else. I'll just show you a case. A 14-year-old female presents with pain, redness, and watering, blurred vision for a month, diagnosed as hyphema with secondary glaucoma. She did complain of trauma to the eye while playing, so the hyphema was attributed to trauma. Despite systemic steroids, full dose given for 3 weeks, she kept on bleeding. You can see one layer of old blood and another layer of fresh blood, and the pressure was very high. She was referred to a glaucoma specialist who had recently published a study on primary trabeculectomy in patients with hyphema with secondary glaucoma, along with hyphema drainage for that particular procedure. So this glaucoma surgeon was very astute, and he observed that the iris was slightly thickened. He did a UBM and he found that there was nodular thickening of the iris. which it has no business to be there in a patient with traumatic hyphema, if it were to be traumatic hyphema. So obviously this was an infiltrative disorder. And when we did peripheral blood smear, bone marrow biopsy, and systemic survey, it was all negative, mainly because the patient was already on full dose oral steroids. So you can easily miss these patients on routine evaluation unless you realize that the patient is on full dose oral steroids. Here, iris biopsy confirmed the diagnosis that it was AML, and of course the patient was treated. And for the eye, since chemotherapeutic agents don't reach the eye in enough concentrations, generally a diffuse nature of this condition deserves external beam radiation, and you can see iris structure normalizing following external beam radiation. And that was the site of iris biopsy that is still visible with a small membrane formed at the posterior aspect, and the iris has completely got normalized with complete resolution of hyphema. So this is one of the manifestations of AML. Let's go to ciliary body metastasis, which is very rare. Unless you actually do imaging, you may miss a ciliary body metastasis. You should look for subtle hints such as a shallow anterior chamber in a sector, particular sector, or a few claw covers as a hint to the presence of a ciliary body mass, or sectoral iris neovascularization. The peripheral iris neovascularization, not at the pupillary margin, would also hint that there could be underlying ciliary body tumor. This was a patient with carcinoma rectum, a known case with multiple systemic metastasis. He also had the sentinel vessels, which are actually very characteristic of a ciliary body tumor. They're very characteristic of a melanoma, ciliary body melanoma. But any ciliary body tumor which is vascular in nature will have this dilated episcleral vessels dipping into the sclera. These are called sentinel vessels. You can see florid vasculature, and otherwise his anterior segment looks normal. And on B scan, of course, he had a large ciliary body mass which was irregular, and he had multiple metastases as well. Now going on to choroidal metastasis. As we already mentioned, it's the most common malignant intraocular tumor, and very importantly, this is extremely important data for an ophthalmologist to understand. 25 to 50%, in some series, even two-thirds, present without a known primary at all. That means patient is not aware of the fact that he has a malignancy in his body. So the history in such patients is of paramount importance. We have to ask for all possible cancer symptoms and look for all possible external signs of cancer in these patients if you clinically suspect a choroidal metastasis. And also, it's important because if you miss the diagnosis of choroidal metastasis, you're going to miss the primary tumor as well. So, since you are the first person the patient is consulting, it's your responsibility to not just diagnose the metastasis, but also possibly guide the patient for appropriate investigations. Now, symptoms depend on the location of the metastasis. Most of the metastases happen in the posterior pole. So these patients will have some amount of visual symptoms. It could be photopsia, scotomas, blurred vision, metamorphopsia, micropsia, macropsia, depending on the size and location of the tumor and the amount of subretinal fluid and the location of subretinal fluid. And when you look at the fundus, you find, depending on the age of the metastasis and the primary tumor, it has a huge spectrum. It could be creamy yellow, as seen in CA breast, to orange red, as seen in renal cell carcinoma. In between that, the whole host of colors and secondary features. Chronic metastasis that's been there for a long time, and the primary tumor is being treated with chemotherapy, will present with a flattish, placoid, irregular surface lesion with retinal pigment epithelial hypertrophy and atrophy. Typically, a yellow plateau-shaped lesion with subretinal fluid is how a metastasis looks like. Typically, that's how it looks. It's not totally a dome-shaped or a highly elevated lesion, typically. But that's the other end of the spectrum. You'll see that as well. I'll show you some pictures. It's called leopard spot pigmentation or RPE mottling. On B scan, you may find a dome-shaped lesion with variable internal reflectivity, acoustically hollow to high, depending on the compactness of the tumor, depending on the necrosis within the metastasis. A lot of other factors, whether the patient has been treated previously with chemotherapy, etc. They could also be an irregular contour and a placoid tumor as well. On OCT, there will be subretinal fluid, shaggy photoreceptors. This is how a typical B scan would look like. In melanoma, the contour would be much higher, height would be much higher. Here, you find a high base to height ratio. That means that the height is smaller and the base is larger. Whereas in melanoma, it is the other way around. Height will be larger and the base is relatively smaller. B scan is typically echo dense and A scan shows high internal reflectivity in this patient, but it can vary from low to medium to high internal reflectivity, sometimes even with bizarre configurations. And sometimes B scan shows uh, acoustic hollowing and also a reverse orbital shadowing. On OCT, this is a typical picture. Of course, there is a spectrum again. This is a patient from a metastasis from a breast cancer showing subretinal fluid here with shaggy photoreceptors and lumpy bumpy tumor surface. So these are the terms that are used to describe a choroidal metastasis on OCT. Now, when you look at autofluorescence, you find that there is hypofluorescence all over except for areas of RP clumping that may manifest as hyperfluorescence. Of course, that is all subretinal fluid. So autofluorescence is a good tool to diagnose choroidal metastasis. Now, classic science Shields description of creamy yellow lesions in the posterior pole, multifocal bilateral, mainly for CA breast. This is typically supposed to be creamy yellow, whereas rest of the metastases are different in color. Gas plaques are mainly for NHL. This is how Shields described creamy yellow multifocal bilateral lesions in a patient with CA breast. This is absolutely typical. There's hardly any differential diagnosis if a patient were to present to you with multifocal bilateral creamy yellow lesions. Very, very typical. But if a patient's present with a unilateral, unifocal, slightly dome-shaped, elevated lesion with subretinal fluid with no RPE changes, then there could be a diagnostic dilemma. This could be a amelanotic melanoma, this could be a choroidal granuloma, this could be a, say, for example, you know, anything for that matter, including what else is possible? Choroidal lymphoma, right? So you actually look at the amount of subretinal fluid, secondary features such as retinal pigment epithelial changes, and also the duration of symptoms, right? And vitreous involvement. Changes in the blood vessels and congestion or edema of the optic nerve head also give you certain clues. If it were to be a choroidal granuloma for that matter, there could be satellite lesions, there could be vascular sheathing, there could be vitreous exudates, there could be vitreous cells, there could be congestion of the optic disc. If it were to be choroidal lymphoma, then the subretinal fluid will be much less. If it's a choroidal metastasis, then the subretinal fluid will be disproportionately more. So that is how you sort out the clinical differential diagnosis. But the picture itself is not diagnostic of choroidal metastasis here. It definitely would have a differential diagnosis, whereas this is very typical. So you should realize that there are situations where there could be diagnostic dilemma. This again, a dirty yellow lesion with RP changes can again pose diagnostic dilemma. So whenever there is diagnostic dilemma, you depend on ancillary investigations such as ultrasound B scan, MRI. MRI melanoma is very typical. PET CT scan to see if there is any primary tumor at all, or if you're looking at lymphoma. And finally, if there is continued diagnostic dilemma, you may have to do a biopsy in a patient where no other clue is evident to fix the diagnosis. This is a patient with CA lung with choroidal metastasis. You can see dirty yellow mottled appearance, posterior pole lesion with some amount of subretinal fluid. This is omental carcinoma with choroidal metastasis, our own patient, where it actually looks quite dark. Perhaps the photography that shows it much darker than what it is, but it was darker colored lesion, which was an omental carcinoma. Generally, when there is a dark colored metastasis, considered primary would be a cutaneous melanoma, but cutaneous melanoma typically produces retinal metastasis and not choroidal metastasis. Now, this was a patient with CA breast with regressed choroidal metastasis because the patient was already on chemotherapy, except this particular edge which looked creamy. But then there is no SRF, there are no visual symptoms. The patient is already on targeted therapy on a long term basis, so we really don't have to treat it. So, this patient needs to be simply observed because there is nothing that we need to treat. If a patient of this sort develops visual symptoms because of SRF, etc., then you may want to do transpupillary thermotherapy, laser photocoagulation, or anti-VEGF, etc. But generally, when a patient has no symptoms and is already on treatment for systemic metastasis, you let the patient be and not specifically intervene for the eye. Now you are looking at a much flatter metastasis. It's somewhat like this. So this is very typical of a patient who is on active treatment, still on active treatment. Whereas on B scan, it shows this undulated appearance. So that's again irregular contour, placoid contour are all features of patients who are on active treatment, systemic chemotherapy, because of which the lesion changes in its configuration and architecture. This is a similar patient where the treatment, systemic treatment is complete. That means that the patient has completed the entire course of systemic chemotherapy and the choroidal metastasis has also regressed partially or fully. That only time will tell if there is any change in its features, and we assume that it is still active and you may want to treat choroidal metastasis specifically. In a patient of this sort, if there is active choroidal metastasis causing visual symptoms despite completion of everything that needs to be done for the rest of the tumors in the body, then you would either give radiation to the eye in terms of external beam radiation or do plaque brachytherapy. Yes. Where is the primary?
It looks more orangish yellow from renal.
Okay. If not renal, then renal cell carcinoma, then
Carcinoid.
carcinoid, then papillary carcinoma of the thyroid,
Thyroid.
right? These are some of the primary tumors which cause a orange colored metastasis. So this was a patient where there was carcinoid, right? Again, orange colored metastasis. You find orange colored metastasis also in CA thyroid, as we mentioned. So orange colored metastasis would direct you to the primary tumor, clearly. Now, this was a patient where there was, see, iris, ciliary body, and choroid as isolated sciences, fine. But some patients will have overlapping metastasis. This was a patient with carcinoma ovaries with iris metastasis, as you see here, and also choroidal metastasis. So, since there was media haze, we did a MRI and we found that there was a ciliary body and a choroidal mass as well. So, this was iridociliary choroidal metastasis. So, that is possible, overlapping. This was a patient again with a CA lung with iridociliochoroidal metastasis in the right eye and vitreous metastasis in the left eye. Vitreous haze itself is metastasis. In fact, the most common primary for vitreous metastasis would be a skin melanoma. That's been reported earlier. But this patient, we found vitreous metastasis. You can see clouds in the vitreous, in the anterior and mid-vitreous, and also some feature of uveitis. In a patient who has carcinoma lung with uveitis, you suspect that the patient may have been given target therapy. That's one of the reasons for uveitis. But even otherwise, they can develop uveitis, and she has a gross iris metastasis. And you can see similar uveal metastasis, vitreous metastasis in the right eye on ultrasound B scan where fundus was not visible, and a small area of choroidal metastasis as well. So multifocal metastasis is possible in the eye. As we discussed already, small choroidal metastasis with SRF can be treated with transpupillary thermotherapy, ICG enhanced transpupillary thermotherapy. For medium-sized lesions, you can treat easily with plaque brachytherapy. Plaque fits into the scheme. If the tumor is multifocal, bilateral, or too large to be in the realm of plaque brachytherapy, then you can use external beam radiation. Or if a patient has multifocal metastasis involving iris, ciliary body, and choroid, again external beam radiation would be appropriate. If a patient has very severe symptoms, painful blind, disorganized eye, then enucleation would be appropriate. So let's go on to retinal manifestations. Retinal metastasis is extremely rare, less than 1%. If ciliary body is 2%, this is less than 1%, mainly possibly because of blood retinal barrier. That is something that may hold back retinal metastasis. And if at all it happens from CA lung, breast, as they're most common, melanoma and adenocarcinoma, etc. So this was a patient of adenocarcinoma lung with typical retinal metastasis. This is from the Shields published series. Very typical retinal metastasis where there is intraretinal and subretinal hemorrhage, vascular occlusion, vascular sheathing, etc. You can see very, very typical OCT as well. It shows that clearly retina is involved and not choroid. This was a patient with a history of amputation of the great toe. The reason was unknown. Patient was not able to recall why the great toe was amputated. Finally, it turned out to be a melanoma of the nail bed. That was the reason why the great toe was amputated. Now, the patient comes with a retinal dark colored lesion. So, very difficult to diagnose this if you don't know the history. You can only suspect such a small lesion, it's not even biopsiable, presumed retinal metastasis from a melanoma. Cutaneous melanoma can metastasize to retina. So retinal manifestations also include leukemic retinopathy. Now in leukemia, retinopathy is caused because of two reasons. One is leukemic infiltrates themselves, or it could be secondary to hematological changes. Sometimes there's a mixed picture. The patient will have leukemic retinopathy, which is infiltrative. Along with that, the patient will have obviously hematological changes as well, such as anemia, that can get superadded. So what are the changes that you see? You see perivascular sheathing, retinal hemorrhages, cotton wool spots, and pale centered hemorrhages are called rod spots. So whenever a patient has a rod spot, your index for suspicion for leukemic retinopathy should be very high. Patient can also have choroidal infiltration that will show up as hypopigmented patches, often bilateral and symmetrical. If a patient has a known history of leukemia, whenever there is a sudden history of vision loss, you should look at the eye very carefully because that is how these patients present. This is very typical leukemic retinopathy, flame-shaped nerve fibrillary hemorrhages, disc hemorrhages, pale-centered hemorrhages, white cotton wool spots. All these are typical of leukemic retinopathy, whereas this is a patient with bilateral anemic retinopathy, as in a patient who has known history of leukemia. This is our patient with myeloid sarcoma with subhyaloid and intraretinal hemorrhage. So other hematological manifestations, malignancies can also cause infiltrative or secondary retinal changes. Now, lymphoma is very typical in having retinal affection. Of course, there are two types of lymphoma that can happen in the eye. Intraocular lymphoma could be secondary lymphoma in choroid, or primary lymphoma, primary intraocular, primary CNS lymphoma, which affects the retina and vitreous predominantly. So if a patient were to present with a haze in the vitreous, obscuring the retinal lesions, haze of this sort, or cloud of this sort, or clumps of this sort in the vitreous, along with that, you have this retinal and sub-RP infiltrates. That's very typical of primary intraocular lymphoma. This is mainly retinovitreal manifestation, and it resolves nicely after treatment. Treatment would be either with intravitreal methotrexate or external beam radiation. It resolves very nicely. Now, if a patient has a choroidal lesion, dirty yellow choroidal lesion with RP changes and little bit of SRF, then if it's unilateral or bilateral, as you see in this patient, that is choroidal lymphoma. So choroidal lymphoma is also a manifestation of systemic lymphoma that you should realize, whereas primary intraocular lymphoma has clear association with CNS lymphoma, choroidal lymphoma has association with visceral lymphoma. So you should appropriately investigate these patients. If a patient comes with primary intraocular lymphoma, then your investigation is mainly in terms of MRI with contrast, brain, and also cerebrospinal fluid cytology. Whereas if a patient has choroidal lymphoma, then you should get a PET CT scan done anyway, and also do a bone marrow biopsy. Now, if you look at the OCT in a patient with choroidal lymphoma, it has this typical C-sick tumor surface with or without subretinal fluid. So this is the term that is used. C-sick tumor surface or undulated tumor surface is typical of a choroidal lymphoma OCT. Now going on to optic nerve involvement. There are many optic nerve signs and that are seen in cancers. Papilledema, optic neuritis, optic atrophy could be because of a CNS malignancy. Optic neuritis could also be because of autoimmune mechanism. Infiltrative optic neuropathy is typically seen in lymphoma and leukemia. Paraneoplastic optic neuropathy or PNON is a manifestation of an autoimmune mechanism. So any patient with malignancy, history of malignancy, where optic nerve shows infiltration, you are supposed to do an MRI of the brain with contrast. Even otherwise, if a patient presents with infiltrative optic neuropathy, MRI brain is mandatory with contrast and a systemic evaluation. It could be tuberculosis in our setting, but definitely you should rule out a hematological malignancy in every patient who has infiltrative optic neuropathy. This is a patient with acute lymphoblastic leukemia. So whenever a patient has a relapse, patient may have remission systemically, but if a patient comes to you with systemic remission and loss of vision, and if you find this, that could be the first manifestation of reactivation of a leukemia. This is a case report, reactivation of ALL following remission with optic nerve involvement as the first sign of reactivation. That's because eye acts as a sanctuary for leukemia. Chemotherapy given systemically does not reach the eye in enough concentrations. We recently had a patient who presented with a different picture, but again, with eye being the sanctuary for lymphoma, you can expect that even when the patient is on complete systemic remission, he can still have ophthalmic manifestations. This is a patient where there was intraocular lymphoma and the patient was on intravitreal methotrexate. The patient suddenly developed lateral rectus palsy, and we did a repeat MRI to rule out optic nerve repeat MRI, and we found that there was actually optic nerve and optic nerve sheath involvement. You see gross thickening of the optic nerve in the left eye, and CSF cytology was performed. The patient finally had to undergo external beam radiation. So this was this picture that the patient had, and finally the patient ended up with complete optic atrophy following external beam radiation. So optic nerve infiltration can also happen in primary intraocular lymphoma. Let's go on to the orbit. The orbital metastasis, well, I mean, it's rare, but in the Western world, less than 10% of orbital tumors are metastatic. Perhaps they have included lymphoma also in this. Most common primaries are breast, prostate, lung, and neuroblastoma. In the orbit, it can go anywhere. It can be in the orbital soft tissues, lacrimal gland, muscle, and the orbital bone. Typically presents with rapid or subacute proptosis, ophthalmoplegia, eyelid swelling, and pain. If a child were to have bilateral proptosis with temporal fossa fullness, then without any periocular hemorrhage, then you suspect metastatic Wilms. This exactly similar picture, triradiate lesion centered in the sphenoid wing with orbital intracranial temporal fossa component with periocular hemorrhage or called Rakuna'i sign, then you suspect metastatic neuroblastoma. These are spotters actually. The diagnosis is immediate. If a child were to have unilateral proptosis with subconjunctival hemorrhage, and when you look at the fundus, you find rod spots, the only investigation that you do immediately would be a peripheral blood smear to confirm that the child has not leukemia. This is granulocytic sarcoma. Now, this is a patient where there's a prior history of CA breast. Now, the patient has had lacrimal gland metastasis and also that is extending to SRLPS complex. And you can actually see that she has developed ptosis because of that. So prior history makes it easy for the diagnosis. This is a patient with retroperitoneal leiomyosarcoma with orbital metastasis, a very rare tumor, a very rare metastasis. You can see a huge metastasis affecting and centered on the optic nerve. This is a patient, again, elderly patient with CA breast with orbital and paranasal sinus metastasis. So it comes running through the entire spectrum. This is a patient with NET, neuroendocrine tumor with bilateral orbital metastasis. You can see a huge metastasis on the right orbit, whereas in the left lateral rectus also you find metastasis. This was our own patient with bilateral breast metastasis. In CA breast, some of the breast cancers being serous, and also if a patient were to have serous malignancy of the stomach, there is contradictory enophthalmos. Despite the presence of an orbital mass, if there is enophthalmos, then you suspect that the patient may have either a sclerosing non-specific orbital inflammation, sclerosing variant of tuberculosis, or a CA breast or CA stomach with serous metastasis. Some of these patients present with diplopia as a symptom because they have ocular motility restriction because of desmoplastic activity of the metastasis within the extraocular muscle. You have to very quickly do a biopsy in these patients to confirm the diagnosis, and external beam radiation will be a better approach in patients who have extraocular muscle involvement. This was a patient who preferred to hide her cutaneous lesion. She never gave out the history that she also has a thigh lesion and a lesion on the anterior wall of the stomach. In fact, she had a cutaneous melanoma, which she very carefully hid. She never gave that history. She came with squint and diplopia. That was her history. So, having not noted her skin melanoma, which she had hidden and not given the history about, we went on to do a biopsy of the extraocular muscle. You can see a black tinged extraocular muscle. Upon biopsy, it was confirmed that it was a melanoma in the extraocular muscle. And finally, the patient underwent a systemic evaluation, and we discovered that she also had skin melanoma. So, muscle can get metastasized with a melanoma as well. If a patient were to have a bone metastasis, then prostate is one of the reasons. Prostate metastasis goes to the bone. So we have now seen lacrimal gland, orbital soft tissue, muscle, and bone metastasis. So all the parts of the orbit can get metastasized. This is a patient who's a known case of multiple myeloma in remission, and after several years, he developed proptosis with a triradiate lesion, intracranial temporal fossa, intraorbital component, and this is plasmacytoma in the setting of a multiple myeloma. So triradiate lesions are common in the realm of metastasis. In a child, you suspect Wilms and neuroblastoma. In adults, you suspect Ewing sarcoma and plasmacytoma. Plasmacytoma being a secondary lesion in the setting of multiple myeloma, you can easily diagnose it. Now coming to tumors with extension from contiguous cavities. This was a patient with paranasal sinus tumor. You see a maxilla, prominent maxilla, and also when you ask the patient to open the palate, you find that there's a palatal mass as well. So this was a maxillary sinus tumor with oral cavity extension as well as orbital extension. Now going on to eyelid and conjunctiva. Eyelid and conjunctival metastasis are very rare, often from breast, stomach, lung, and melanoma, and may mimic a small nodule such as lesion or a benign tumor. And when there is a Salmon patch, of course, you are very clear. This was a patient with renal cell carcinoma with a fiery red metastasis. Right? So this was metastasis to the palpebral conjunctiva from a patient with a known history of renal cell carcinoma. These are, of course, all of these are lymphomas. Salmon pink color can never be missed. I'll be brief with neuroophthalmic manifestations. In neuroophthalmic manifestations, we have because of the direct effect of the tumor, intracranial tumor, there could be compressive optic neuropathy, there could be infiltrative optic neuropathy, and there could be ischemic optic neuropathy. These are all direct manifestations of the effect of the intracranial tumor on the optic nerve or the optic nerve tract. And also, again, because of that, there is raised intracranial pressure, because of which papilledema happens. Leptomeningeal carcinomatosis, primary CNS lymphoma can also cause papilledema. Any intracranial malignancy can cause elevated intracranial pressure, because of which there could be papilledema. Cranial nerve palsies are also because of direct effect of the intracranial tumor on the cranial nerves. So most of this neuroophthalmic manifestations are direct, but then there are indirect effects as well. Now, who wants to diagnose this? Mahima?
It's
Patient has ptosis.
unilateral and um, a non-dilating pupil
Do you
in
think
dim
it's
light.
non-dilating or asymmetrical pupil? We haven't
It's
done anything to the
the
pupil.
the right side pupil is meiotic. Even in
Yeah.
dim light, it is non-dilating.
Hmm.
Ptosis, meiosis.
Hmm.
Signs of Horner syndrome.
Yeah, absolutely right. So this is Horner syndrome. So very typical meiosis, anisocoria, poor dilatation, ptosis or inverse ptosis. Inverse ptosis would be higher position of the lower eyelid, enophthalmos, and anhidrosis. So these are the components of Horner syndrome, typically associated with Pancoast tumor. Let's move on to paraneoplastic manifestations. So paraneoplastic manifestations by definitions are remote effects of cancer, not due to direct tumor invasion. Most of these are autoimmune in mechanism. In the uvea, we have BDUMP. What is BDUMP? Bilateral diffuse uveal melanocytic proliferation, right? And we have retinopathies. Retinopathies are CAR and MAR, cancer or carcinoma associated retinopathy and melanoma associated retinopathy. Then we also have acute exudative polymorphous vitiliform maculopathy called AEPVM and paraneoplastic optic neuropathy. So these are the paraneoplastic manifestations that we must be aware of. Now, BDUM is nothing but paraneoplastic proliferation of benign melanocytes. So they are normal uveal melanocytes, but they undergo nodular proliferation, sometimes diffuse, sometimes isolated nodular. These are typically associated with ovarian or pancreatic carcinoma. So if a patient has BDUM, you know the primary already. They could be the initial manifestation of an unknown primary. They could be synchronous along with the primary. They could be metachronous after the primary has been completely eradicated. So they have three settings. You should be aware of that. At the time that you find BDUM, the patient may not have an active primary tumor at all. He may be treated already. So in BDUM, apart from bilateral diffuse uveal melanocytic proliferation, they also have anterior uveitis. Sometimes they have cataract and subretinal fluid. They have not because of uveal melanocytic proliferation, but because of concurrent autoimmune retinal effect, they have bilateral visual loss. So that is the sign, the symptoms that they come to you with. And when the patient comes to you with this acute loss of vision in the setting of a primary malignancy, remote or currently under treatment, there are three possibilities, as I said. One is BDUMP, second would be CAR, and if the patient has a known melanoma, then melanoma associated retinopathy. So initially, BDUMP may be very subtle and may not be seen clearly on fundus evaluation. So you have to do AF. Autofluorescence actually picks up BDUMP very, very easily. So they come with multiple uveal melanocytic tumors if it's gross, and giraffe-like RP changes, exudative RD, uveal thickening, and FA and ICG, you find dual circulation and choroidal hyperpermeability. They have very poor prognosis. Intravenous immunoglobulin, plasmapheresis, steroids, everything may work, may not work, may partially work. This is very, very distinct, BDUM. Very distinct. Whereas if a patient has other manifestations such as RP, mottling, etc., then for the first test that you do would be autofluorescence. It shows up very, very prominently, and on OCT you can see that in the corresponding area there is uveal proliferation. And on FFA in early phases, you find that there is actually block fluorescence because of these changes, right? RP changes are superadded to beta. Now, this is again a patient which is from the literature, leopard spot chorioretinopathy as an outstanding finding in a patient with beta. So BDAM can have various manifestations, some of which is very striking, some of which may be very subtle. Going on to paraneoplastic retinopathies, two types: cancer-associated retinopathy, typically associated with small cell lung carcinoma, CA breast, and gynecological malignancies. Melanoma-associated retinopathy specific to melanoma. Sometimes they precede the diagnosis of systemic malignancy. Sometimes they have a concurrent systemic malignancy. Sometimes systemic malignancy is already treated. Now, for cancer-associated retinopathy or CAR, it is autoantibodies to retinal antigens to recoverin. Recoverin is a specific protein, which is a calcium binding protein that regulates phosphorylation of rhodopsin during visual transduction. If there are autoantibodies to recoverin, the patient loses vision. Initial symptoms may be photopsia, ring scotoma, and nyctalopia. Nyctalopia is typical of melanoma-associated retinopathy. It can also be seen in cancer-associated retinopathy. Primary cancers we already mentioned. On ERG, you find extinguished A and B wave. So you find what is called cone rod degeneration pattern. This is partially responsive to treatment. Steroids now sometimes even given intravitreal steroids, intravitreal triamcinolone in some case reports has shown effect. Immunomodulation using systemic immunomodulations, intravenous immunoglobulins, plasmapheresis, everything works partially. It has much better prognosis than melanoma-associated retinopathy. This is from the literature where you find that the reason for autofluorescence that you find very typical pattern is because of loss of ISOS in the area where there is autofluorescence. So this is normal retina, this is hyperautofluorescent, and that exactly in that area there is ISOS loss and also outer retinal atrophy that happens in this particular condition. Melanoma-associated retinopathy or MAR is associated with cutaneous melanoma. Here, the autoantibodies are to bipolar cells. Symptoms typically night blindness as the predominant symptom, photopsia in some patients. In ERG, you find electronegative response. Normal A wave selectively reduced of totally attenuated B wave. It's a high risk marker. It's a harbinger that cutaneous melanoma may have recurred locally and may have metastasized elsewhere also. So if a patient who had a prior history of cutaneous melanoma were to develop melanoma-associated retinopathy, the complete oncological evaluation to rule out recurrent cutaneous melanoma or systemic metastasis from cutaneous melanoma, and it is refractory to treatment. Unfortunately, it is a bilateral condition. This was a case of melanoma-associated retinopathy with autoantibodies against TRPM1. So this is from the published literature, where you also find that there are nodular excrescences. So nodular excrescences in the choroid can also happen along with this condition. So here you find that the visual field is almost completely obliterated, severely depressed visual fields, and full field electroretinogram shows reverse negative waves of combined responses and decreased amplitude of photopic response, more in the left eye, and multifocal ERG shows decreased central retinal responses in the left eye. Now, how do you diagnose this? Sometimes diagnosis can be very tricky. You don't know what you're dealing with, especially if a patient does not come with a history of prior cancer and there is no primary known. You do this serology. If a patient you're suspecting cancer associated retinopathy, you have to look for anti-recoverin titers. Also can be tested are anti-alpha enolase, anti-transducin, anti-carbonic anhydrase. If a patient has BDAM, there is no associated antibody that can be tested. Melanoma-associated retinopathy, what you test are anti-transducin B, anti-rhodopsin, and anti-arrestin. So depending on your clinical suspicion, if you have the facilities available, you can get these tests done. Anti-recoverin antibodies testing is available currently, but rest of these may be available in certain centers. So there's a complete list of what tests that you can do for paraneoplastic syndrome, which I think is too detailed for this talk. There are other paraneoplastic syndromes as well: paraneoplastic optic atrophy, Eaton-Lambert myasthenia syndrome with ptosis and diplopia, opsoclonus myoclonus syndrome, specifically in neuroblastoma with children, ocular myasthenia as a part of thymoma, stiff person syndrome because of glutamic acid decarboxylase antibodies may have diplopia and nystagmus as an ophthalmic feature. Otherwise, the patient has limited flexion and extension. Stiff person syndrome is a known disease. So in paraneoplastic optic neuropathy, you find autoimmune mediated damage to the optic nerve. Patient comes with subacute vision loss with disc swelling or pallor. It may be isolated or may be associated with cancer associated retinopathy, often linked to small cell carcinoma of the lung. This is a patient where there is bilateral ptosis and on eye test. It is positive. This is very typical of myasthenia. This patient does not have myasthenia as part of, say, paraneoplastic syndrome, just showing you as an example. But any patient who has a prior history of cancer, or an elderly patient suddenly presenting to you with ocular myasthenia, or a young patient, a child presenting to you with ocular myasthenia, you should suspect that myasthenia could be a paraneoplastic manifestation. In younger individuals, you should definitely do a CT thorax to look for thymoma. Otherwise, it could be a part of stiff person syndrome as well, or other paraneoplastic syndrome where myasthenia could be a part of. The last bit is about hereditary cancer predisposition syndromes. Mainly these are spotters. I mean, if you look at the list, it is daunting. There are so many hereditary cancer predisposition syndrome. Many of these can affect the eye. So I'm not going to go into the details because these are absolutely rare. These are definitely not for the residents. And I wonder if even fellows would try to remember any of these or many of these. Look at the list. And the entire list is available in the article in the Journal of Clinical Oncology by Gerber. It's a very highly cited article, 900 plus citations for this particular article, highly cited one. Now, let me ask these as spotters. Ashwita, if you find a patient presenting to you with this mass, what associated syndrome would you suspect? Yellowish nodular mass in the lid margin involving the tarsus. Lashes are there, sparse. When you do an excisional biopsy and you find that it is not sebaceous gland carcinoma, but indeed a sebaceous adenoma, then what would be your... I can't hear you.
The Molitor syndrome, adenocarcinoma of the colon could be present.
All right. Okay. If a patient were to have one seborrheic keratosis, you really don't worry. But if a patient has multifocal seborrheic keratosis, then what do you suspect? Bilateral multifocal seborrheic keratosis, you ask the patient to take off the shirt and you feel hundreds of these, then you suspect this associated adenocarcinoma, this sign of Lacertrella, right? Okay. If a patient were to have this fleshy pink lesion, not lymphoma, and also pigmentation of the caruncle, plica, lid margin, periocular pigmentation, pigmentation of the lip, mucocutaneous pigmentation, then you should answer this. We already discussed this. Anybody can answer. Megha, unmute yourself. All of you unmute yourselves. Farnaz.
Would it be an amelanotic melanoma?
Possible, but anything more typical? I said mucocutaneous pigmentation in the setting of a conjunctival stromal lesion.
Cost.
How much more clue can I give?
Cost.
This
Yeah.
is conjunctival myxoma, cost. Carney's complex is the association, which is a hereditary cancer syndrome, typical to have spotty mucocutaneous pigmentation, myxoma of various tissues, including the heart, which can be very detrimental, other benign or malignant tumors, and endocrine hyperactivity. Can also be associated with Name and Lamb syndromes. Nave would be nevi, atrial myxoma, myxoid neurofibroma, and ephlides. Lamb is lentiginous atrial myxoma and blue nevi syndrome. So difficult to remember all this, but if a patient has a conjunctival myxoma cost, you should definitely look for systemic investigations. No, yeah, Farnas,
You can call me.
yeah, association.
Um, Multiple endocrine neoplasia, type
Absolutely correct.
2B.
So, yeah, then you look at the patient's lip and tongue. Patient has neuromass of the mucosa. That is definitely suggestive of MEN type 2B. Mucosal neuromass, marfanoid body habitus, medullary thyroid carcinoma, pheochromocytoma, and thickened corneal nerves are typical of MEN type 2. This one, Mahima.
Hi, sir, this is retinal capillary angioblastoma as a part of von Hippel-Lindau syndrome.
Correct. So even optic disc hemangioblastoma can also be part of VHL syndrome. And in the patient with VHL syndrome, there are other manifestations such as cerebellar hemangioblastoma, renal cell carcinoma, pheochromocytoma, pancreatic tumors, spinal cord angiomas, etc. So you have to investigate them. Again, as an ophthalmologist, if you encounter a patient even with unilateral unifocal retinal capillary hemangioblastoma, the first test that you do is VHL gene, if it is possible at all. It is available, it is possible, so you should do it. And actually, the ophthalmologist is a person who sees these patients first, because retinal capillary hemangioblastoma occurs first of all. And depending on the location, if a patient has blurring of vision, visual symptoms, he will come to an ophthalmologist first. And if you miss the opportunity to screen them, they may go on to develop cerebellar hemangioblastoma and renal cell carcinoma. So if you have already diagnosed a patient as VHL disease, if you have done VHL gene, and if a patient has unifocal unilateral tumor and VHL gene is negative, then screening need not be tight at all. But if a patient has VHL gene positivity, or if a patient has unilateral, multifocal, or bilateral tumors, then screening should be very tight, not just for the patient, but for the entire family. So it has a lot of implications, some of which are life-threatening. So you should take this very seriously. Okay. Now, if a patient were to have congenital hypertrophy of retinal pigment epithelium, if it is unilateral unifocal, the typical circular chirpy, no problem. But if a patient were to have bilateral extramacular chirpy with deep pigmentation, sharp margins, and almost like a fish with a small tail, fish, the pigmented part, and the tail of depigmentation, and more than 4, then that is invariably associated with Gardner syndrome. The patient and the entire family has to line up for an endoscopy, colonoscopy in such patients, because this could be the first manifestation that might have come to you. Complications of treatment, I'll be very brief. Well, radiation-induced complications, most important would be radiation retinopathy. It may look like diabetic retinopathy. If a patient has undergone radiation to one eye, then there would be acceleration of diabetic retinopathy. It will be more advanced than the other eye. So radiation retinopathy is one of the complications, apart from dry eye and keratopathy, as consequences of radiation. Now, threshold doses, you must remember, for retina, it is 4,500 centigrade. So if you exceed that, then the chance of radiation retinopathy would be high. For optic nerve, 5,000 centigrade, if you exceed that, then there could be a chance of optic neuropathy. Typically, radiation retinopathy is treated with anti-VEGF and, just like diabetic retinopathy, laser photocoagulation. Now, chemotherapy and target therapy induced complications are quite common. Cisplatin can cause optic neuropathy. Tamoxifen can cause crystalline maculopathy and CME in the eye. Immunotherapy can cause any immunotherapy for that matter can cause uveitis, VKH-like syndromes. It may look exactly like VKH. BRAF inhibitors causes central serous retinopathy-like changes. MEK inhibitors cause serous retinal detachment. So if a patient comes to you with young patient or elderly patient comes to you with any of these, then you should ask them for a history of target therapy, which they may be taking for their systemic malignancies. If a patient has undergone BMT, then graft versus host disease, they present with keratoconjunctivitis sicca and very severe ocular surface problems. Cataract can happen from total body irradiation associated with BMT. They can also have infectious retinitis. Any patient who is on immunomodulation for any reason can have infectious retinitis. Optic neuropathy, which will be post-transplant neurotoxicity. So in all these patients who have ophthalmic manifestation of systemic cancers, many of these patients may come to you for the first time without knowing that they have a cancer, or having known that they have a cancer, having been cured of it, they may not give you the history properly, but then they may come to you with ophthalmic manifestations. So you should have a very high index of suspicion and take appropriate history to uncover the presence of a malignancy. So your investigation should be very thorough, apart from all relevant ophthalmic investigations, systemic investigations, and specific serum markers, especially in patients with cancer-associated retinopathy, are important to diagnose. Then obviously you will treat all these patients in collaboration with an oncologist as appropriate. Thank you so much.
Thank you, sir. So I'm very sure that it was really a comprehensive coverage, and the way you classified like from anterior to posterior, that helped us a lot in dividing and also understanding each and every segment. So I'll just ask a few questions which we actually have. So to begin with, so we know like the most common malignant intraocular tumor in adults, choroidal melanoma. So what are the
Primary.
primary. So what are the indications of PET-CT? Otherwise, like how do we request for a PET-CT when we see a choroidal tumor? Like how do we suspect?
No, you're talking about choroidal melanoma. What are the indications of PET-CT scan?
Yes, sir. Yes, sir.
So any patient, any size choroidal melanoma, baseline PET-CT scan has to be done, because we now know that metastasis from a choroidal melanoma can happen in a small tumor, which is like 3 millimeter in diameter, 1.5 millimeter in thickness, Kivela study. So PET is mandatory for every patient that you see with primary choroidal melanoma. Baseline.
Okay. All right. So, okay, sir. And are there like any apart from the metastatic, I mean, choroidal metastasis being flat, creamy, yellow, are there any atypical features like which we should have in mind as well in order to differentiate if it's a primary or a metastasis?
Yeah, very difficult, because this spectrum is so huge. As I showed you, it can present right from a placoid creamy yellow lesion to a pigmented large dome-shaped lesion to a flat pigmented lesion. So, see, you have very few intraocular tumors, isn't it? Very few adult intraocular tumors. Most of these are very typical, right? Melanoma looks like a melanoma unless it's a amelanotic melanoma or a necrotic melanoma, isn't it? So if you have anything that is atypical, does not fit into the diagnosis of a primary tumor, you should suspect a metastasis in an appropriate age. Doesn't mean that in a 20-year-old with choroidal hemangioma, you start doing extensive investigations. That's not right. So if a patient has a choroidal hemangioma, it is very evident. It is always unilateral unifocal, present at the posterior pole, orangish hue with subretinal fluid, induced hyperopia, all that features of being there in a young patient, you really don't have to do a PET-CT scan. But if you find that a patient who was otherwise normal has undergone a thorough ophthalmic evaluation just 6 months back by a well-qualified, astute ophthalmologist, suddenly develops blurring of vision with an orangish choroidal mass, 70-year-old, then you don't suspect that the patient would have developed a choroidal hemangioma in 6 months at the age of 70 years. obviously it is a metastasis, right? Now you know that it's an orange colored metastasis in a 70-year-old, you know where the primaries could be, so you appropriately investigate the patient. So you have to take the entire clinical setting into consideration before you advise investigations. That's very important. You should not miss doing investigation in a deserving patient. At the same time, you should not overdo investigation when it is not necessary, just for the safety of your clinical practice. So clinical triaging is extremely important in medicine, so that you pick up lesions which can be missed and don't do investigations needlessly in patients where it is not.
Okay. So demographics do matter. Okay.
Demographics, entire clinical picture, right from the history. Look at all the old photographs, get records, medical records from prior ophthalmology. If the patient carries a fundus photograph, that's great. Look at the chronology of the event. So then you arrive at a differential diagnosis, and if any metastasis is in the list of your differential diagnosis, and if you cannot rule it out, then of course you would investigate.
Okay. All right. So the next question is, you explained about retinal metastasis in leukemia, how the infiltrates and all. If not for leukemia, if it is from a systemic malignancy, like how is the presentation in the retina?
Flat lesions.
Okay.
Yeah, creamy yellow adenocarcinoma, dark pigmented melanoma. The one which I showed is a melanoma, cutaneous melanoma metastasizing to the retina. Retinal metastasis is extremely rare, so you really don't have to worry about it. Even a ocular oncologist would see probably 2 or 3 cases in lifetime. The largest, the entire collection of series would be about 30, 40. I mean, it's very, very rare, so you don't worry.
Okay. So, in choroidal melanoma, actually, we do not do a biopsy. Are there any specific indications where a choroidal biopsy will be required?
Yeah, choroidal biopsy would be required for 2 reasons. One is that if you want to do a genetic test to risk profile a patient in a choroidal melanoma, even if you're doing plaque brachytherapy, then you can do a choroidal biopsy, tumor biopsy. That is being routinely done in the West. Because they want to have this information. Suppose a patient were to develop a systemic metastasis, right? The second would be if a patient has a choroidal melanoma which is atypical, amelanotic choroidal melanoma, inappropriate age for choroidal melanoma, child with a choroidal tumor, correct? Or inappropriate clinical findings. So then your diagnostic dilemma is definitely there. So you want to do a biopsy before you treat the patient.
Okay. All right. So, can you explain a little, what is the role of AC tap, vitreous tap, and also liquid biopsy?
Liquid biopsy definitely has a role. Retinoblastoma, liquid biopsy does have a role. Of course, not for diagnosis. Retinoblastoma is a clinical diagnosis, but if you want to actually see, so actually it could be a predictor of retinoblastoma recurrence. Depending on liquid biopsy, you can actually see if a particular patient has a recurrent lesion or it's just not a recurrence, regress lesion. So there are possibilities in liquid biopsy can have a lot of indications in the future, but right now it is being done to see if it comes positive. Even melanoma, liquid biopsy can be performed. So liquid biopsy is the buzzword in all malignancies now. So it will have its own indications for sure in clinical practice. But right now, if the facilities are available, you can do it to gather data and see how it works for which patient and what would be the indications finally. Vitreous biopsy is done mainly for primary intraocular lymphoma. And there's a specific way of doing it. Diagnosis of primary intraocular lymphoma is mainly dependent on vitreous biopsy. If you're suspecting vitreous metastasis in a patient with a prior malignancy, then again you can do vitreous biopsy.
And the next question would be, in hematological malignancies, whenever we have a subhyaloid hemorrhage, ILM bleed, especially at the macula. So if all the blood parameters are corrected, what is the role of surgery in clearing the bleed for visual potential?
Yeah, so if there's a macular subhyaloid hemorrhage, then obviously you may have to intervene rapidly. Otherwise, clearing systemic parameters takes time. It's not immediate. So in the meanwhile, if you want to visually rehabilitate the patient and avoid secondary effects of all this, you can intervene. There is a role for surgery in these patients if the vision is affected.
Okay. All right. So, just one more question. So, in radiation retinopathy, so we call early radiation retinopathy and late. Is there a specific time which is involved in differentiating either or?
No. It's not the time. Depending on the dose and the predisposition of the patient. If a patient has diabetes or any sort of microvasculopathy, then the chance of developing radiation retinopathy is higher. If the dose is higher, then the chance of developing radiation retinopathy is higher. If a patient has prior chronic long-standing retinal detachment, again, chance of developing radiation retinopathy may be higher. So depending on the manifestation, it is not time bound that you call it early or
Late.
advanced. It's the manifestation, the signs that you see that will help you label whether it is early radiation retinopathy or florid. There are staging systems also for radiation retinopathy. So that's how it is.
Okay. And might be a basic question, sir. How does retinoblastoma shows such a significant response to chemotherapy, whereas uveal tumors, our first modality is usually radiation, despite the blood supply?
So nature of the tumor itself, round cell tumors show very good response to chemotherapy. Melanoma, unfortunately, does not have a chemotherapy protocol for primary management of melanoma, uveal melanoma. There are chemotherapy protocols for metastasis and also to prevent or reduce the risk of metastasis in high-risk uveal melanoma. But those are, I believe, still experimental and nothing that is clinically has a definitive role even in uveal melanoma. So it depends on the biological nature of the tumor itself, whether a particular tumor responds to chemotherapy or not.
Thank you, sir. Thank you so much. It was really an honor to have you with us today for this session. So with that, we conclude the session, but I would like to remind you about the Physical iFocus 2025 this year, the largest national postgraduate education program in ophthalmology, this time again in New Delhi from August 10 to 17. Extremely limited seats are still available, so hurry up and book your slots. So we meet next for the iFocus session on Friday, 18th of July. And the class will be on eye and dermatological diseases by Dr. Arshi. Thank you so much for joining. Have a good night.